Question number 20, which of the following findings would best support this patient's most likely diagnosis? And then just right away, like really without reading very much, you just see a bunch of PFTs and like, this is a pulmonary question. A 64-year-old man presents with a gradually worsening dyspnea over the past year. He reports a dry cough, but no chest pain, fever, or sputum. He previously worked as a stone cutter and smoked for 20 years before quitting 15 years ago. Yeah, so they always give you like weird history that nobody ever bothers remembering what it actually does. Stone cutter is definitely one of them. Like, what on earth does that actually mean? So stone cutter is definitely an exposure. We'll talk about that later. But so is smoking. Smoking is a bad exposure too. So the real question is smoking the problem or is it stone cutting that's the problem? Even if you don't know specifically what stone cutting does, you probably know enough about lung disease to know that that's bad for you. Physical exam reveals digital clubbing and fine end inspiratory crackles at the lung basis. So we got crackles again without wheezing. No wheezing. Great. I like this question. There's a lot. They tell you a lot. Even if you don't know what the specific condition is, you should know what type of lung disease this is. So just think about this. Where do you ever hear wheezing? What's probably the most common condition you've heard wheezing associated with? Asthma. Like every time. Always asthma. Have you ever heard of stridor though? Stridor is kind of on the same lines. Wheezing is due to obstructed airways. So when the airways are obstructed, as air rushes through them, like the bronchi, for example, or the bronchioles, it makes this noise that we hear called wheezing. Same thing with stridor. Stridor is basically wheezing for bigger airways, like the trachea. If the trachea is narrowed, then you get a slightly different sound. It's not wheezing anymore. Now it's stridor. So wheezing clues you in on obstructive lung disease. Very, very important. Asthma equals obstructive. If you didn't know asthma was obstructive, now you know. I find a lot of students don't know that. So this is good to clarify. So wheezing equals obstructive lung disease. So thinking of other obstructive lung diseases like COPD, what are the two types of COPD? Emphysema, chronic bronchitis, right? You're probably not going to hear wheezing with emphysema because the mechanism of emphysema is not narrowing of airways, it's destruction of alveoli. But chronic bronchitis absolutely is, right? So asthma and chronic bronchitis can both present with wheezing because they're both obstructive and specifically they deal with narrowed airways. Now, another thing we talked about in an earlier question are crackles. Crackles are classically heard with two conditions on board: fluid in the alveoli or interstitial lung disease. Now you just ask yourself, which one do you think is actually happening based off of this stem? Did they give you any cardiogenic causes to think of cardiogenic edema? No. Did they tell you he has pneumonia or any symptoms of fever? Nothing, right? So it's probably the stone cutting, right? If we were to guess. And if you were to Google it, you'd know that stone cutting may be a cause of silicosis. And silicosis is essentially just interstitial fibrosis. But again, you didn't need to know any of that. You just needed to know what wheezing is and what crackles are. So why do crackles actually happen? Well, here we've got our alveoli here. Each little sac is an alveolus. And then this blue stuff, this is your interstitium. And this is supposed to represent like scar tissue from silicosis or other interstitial lung disease. Now, when you are following the arrows here, when you inspire, it looks something like this. The alveoli are open and you've got this like stretched out scar tissue. But then as you expire, you breathe out. Now the alveoli kind of collapses in on itself. And you can see how this scar tissue really contracts down and holds the alveolus closed, the alveoli closed. And so then when you inspire, right, the expiration process is not where you hear the crackle. It's on inspiration, when all of a sudden the alveoli pop open. It's literally that popping sound that you hear as the alveoli open up all of a sudden. So as air rushes in, right? It's filling up with pressure until all of a sudden it just pops open, and that's where the crackle sound comes from. So we know we're dealing with restrictive lung disease. We just have to pick an answer choice that is restrictive lung disease and hope there's not more than one. Because if there is more than one, then we'd probably need to actually know something about what stone cutting is related to. So starting at the top, flattened diaphragm on chest x-ray. If that is not screaming COPD, barrel chesting, then go directly to jail. Then we've got B, decreased diffusion capacity, DLCO. So it's just the ability for carbon monoxide, specifically carbon monoxide, but it's really just, it's any gas, but DLCO is specifically carbon monoxide. The ability of that gas to diffuse across the alveolar capillary barriers or membranes. So there's a lot of lung disease that impacts DLCO. Do you think interstitial fibrosis would, right? Like, let's just draw it out. Technically, you do have like the alveoli and the capillaries are flushed here, but let's say this happens and it builds up between them, or it's really just on top of the alveoli. Right now your capillaries are out here. Well, yeah, it's going to be harder to get air into the capillaries. So sure, B could be it. We can't just pick it and move on though, because we haven't read any of the other ones. And you have to also think, well, what if you had emphysema? Emphysema is just taking our alveoli and turning them into, it kind of looks like a cauliflower, essentially just one big paper bag. So we've taken all this surface area from all these alveoli and we've gotten rid of it. It's been destroyed. So if you have less surface area, you're going to have less ability for gas exchange to happen. And so you decrease your DLCO with emphysema as well. So B is not specific to our restrictive lung disease. Productive cough with purulent sputum. This kind of sounds a lot like chronic bronchitis. So I'm going to cross that one off. Decreased FEV1 to FVC ratio. Decreased. So let's just think about this. FEV1, this is forced expiratory volume in 1 second. So it's how much air can you get out in 1 second. You just take a deep breath and you breathe it all out as quickly as you possibly can. Over FVC, forced vital capacity. So this is just taking a deep breath and breathing all of it out with no time component. It's just how much total air can you exhale. So now we're basically taking our rate, dividing it by the total amount of air we can get rid of. So if you have an obstructive lung disease, so now let's think chronic bronchitis here. Let's say we've got our bronchial tree splitting off here, and let's say it's narrowed right here. We've got this inflammation of the bronchi. This pathway is narrowed, and now when air tries to come by, some of it kind of gets deflected. All right, it's not all going to be able to leave. Some of it can, but not all of it. And so you get air trapping. So when you try to exhale quickly, with your FEV1 is going to be impacted because you can't get all that air out as quickly as you could without this inflammation, without this stenosis of the airways. But what about FVC? Wouldn't that be the same? It's actually not. So have you ever heard of the term pink puffers or blue bloaters? People tend to purse their lips when they have COPD, especially chronic bronchitis, when they try to breathe by pursing their lips. So putting their lips together, making a smaller hole to breathe out of. You can breathe less air out per unit of time. So you can't breathe out as quickly by doing that, as opposed to just having your mouth wide open. For example, you can try that. All right, just have your mouth wide open, take a deep breath in and out, and see how much air you can get out versus if you purse your lips and then you try to breathe in and out as quickly as you can. It's a lot faster to exhale with your mouth wide open. So these people with COPD will purse their lips. That decreases the time that they can exhale, but it actually increases the amount of air they can exhale. FVC is usually okay because there is no time component, but FEV1 is definitely drastically decreased. So decreased FEV1 to FVC ratio is describing obstructive lung disease. And specifically, if you see a ratio of less than 70%, it's probably obstructive lung disease. If it is greater than 80%, it's probably restrictive lung disease. So now we got to ask ourselves, well, how do we get this to be high? Well, if we have restrictive lung disease, think about we've got all this pressure here. This pressure is always here. So when you inspire, you still have this pressure from the scar tissue pushing in on you. So it actually kind of helps you expire quicker. You still have a lung disease, so it's not like your values are going to be normal. They're still probably going to be relatively decreased compared to normal, but your FEV1 actually tends to increase. Your FVC, less so. So that's why our ratios are over 80% for restrictive and under 70% for obstructive. And then hyperinflated lungs on imaging is also barrel chesting. So we're left with B. You can rule it out. Again, we went through all of these. They technically all work for obstructive lung disease, but only B works for restrictive lung disease. And that's why that's the answer.